Hi, welcome back everyone to our free NCLEX review session today. We are on day 33 out of the 90 days, and we're also inviting you to enroll in our comprehensive NCLEX review course at Stancoast NCLEX Coaching, where you can access a wealth of resources, over 3,000 NCLEX style questions and 10 hours of animated videos for flexible study. And we really want to help build your confidence by using our on-demand video library and practice exams. So we encourage you to visit at our website at www.stancoastnclexcoaching.com. And for additional details, kindly check out the link below in our description box. And we really value your feedback, and always share your thoughts, your questions in the comments, and we'll be happy to help out. And don't forget to subscribe and like and share this video to your friends. And today, guys, welcome. For those who are in the classroom right now, welcome, welcome, welcome. Now, we will be talking about the congestive heart failure today, and this is something that we probably are familiar, but we'll need to practice some more of the test questions today, and we really need to develop mastery, especially with the complexities in the nursing care management. So let's begin. Now, as we are talking about the congestive heart failure, this is a chronic problem wherein the heart can no longer effectively pump the blood to meet the body's needs. And this is usually going to be the final stage of various health problems. Now, with the congestive heart failure, we're going to have to classify them today into two. Okay, so you probably heard about the diastolic and the systolic dysfunction in congestive heart failure. Now, here we have the classification here. We have what we call as heart failure with reduced ejection fraction. We call this as the HFrEF. Okay, I don't know if you are familiar with this, but this is basically the newest term that cardiologists will be referring to, especially in a case of congestive heart failure. So this is what we call as the HFrEF. This is basically the heart failure with the reduced ejection fraction. Okay, and so this is what we also refer to as the systolic dysfunction. Now, what is really going on in the HFrEF or systolic dysfunction type of CHF? Well, like I have said earlier, the function, especially the pumping ability of the myocardium, is lesser. Okay, so it's basically that the ejection fraction right now is less than 40%. Okay, normally when you're going to look for the ejection fraction in the literature, you probably will be seeing acceptable range of 50% to 70%. Okay, so if your patient is going to have that reduction, let's say less than 40%, wherein there is now a decreased ability of the ventricle or the heart to pump the blood out into the circulation or out into the pulmonary circulation or systemic circulation, this is going to qualify this patient to fall under this classification called as HFrEF. Okay, now, why is this called as systolic dysfunction? We really need to break this down, guys. And so in order you will be able to understand what is a systolic dysfunction, heart failure. Now, it is referred as such because the impairment basically is going to occur when the heart is going to pump the blood. Okay, so it's going to happen in the systolic phase. All right, so the ventricles are not able to effectively push or squeeze the blood out of the heart during the systolic phase. All right, that is why it is called as systolic dysfunction, of course, with an ejection fraction of less than 40%. Now, what would be the effect regarding the decreased EF? Well, this can impact the right and also the left side of the heart. Let me just put my signs here. Left sides of the heart. Okay, So it's just not affecting just the left ventricle, but it's also going to affect the right ventricle as well. Okay, please take note of that. Again, for those who just came into the classroom, welcome, welcome, welcome. I'm glad that you are coming back to learn some more today. All right, so what do you think would be the causes of the HFrEF, or known as the systolic dysfunction heart failure? There's a lot, guys. And one of those is the ischemic heart disease. So in a case of, let's say, MI, or could be the angina pectoris, okay? Eventually, with the progression of the disorder, it can lead to ischemia into the myocardium. And this is probably because of stenosis, atherosclerosis going on into the coronary arteries. And so this will really compromise the blood supply to the muscles, the hard worker layer of the heart, the myocardium. Okay. All right. All righty. Now, we'll talk about the myocardium as well, or recent myocardial infarction, or recent MI. That could also lead to the congestive heart failure. With chronic hypertension, this can also cause much more of a workload by the heart. It will get weaker and weaker and weaker as the time goes by when there is high blood pressure because of that increased systemic vascular resistance. Okay, so here, guys, this is our left ventricle here. So if the person has high blood pressure, HTN, remember about that systemic vascular resistance will increase if the patient has a pre-existing high blood pressure. Remember about the size of the arteries as it kind of moves forward into the systemic circulation, the arteries will be a lot smaller, okay? And on top of that, of course, with the weakening, the high blood pressure, the weakening of the left ventricle, this can also overwhelm this left chamber of the heart and eventually will make it dilated and again, will affect the ejection fraction in the long run. Now we'll talk about the idiopathic cause. We really don't know what caused it. Also myocarditis, which is a common cause, which is the inflammation of the myocardium itself, or it could be caused by some medications, maybe alcohol, cocaine, methamphetamines, which are going to elevate the blood pressure, okay? And some medications like chemotherapeutic agents, these can lead to the HFrEF as well. Now, in some cases, if the patient would require radiation therapy and over time, this can probably expose the myocardium. This can also lead to HFrEF, thyroid disease, valvular disease, especially those atrioventricular heart valves or the semilunar valves. If there is going to be stenosis, regurgitation in those leaflets, then it can also lead to the systolic dysfunction. And of course, if there is going to be anemia, wherein a reduction of a red blood cell is so significant, this will cause the heart to work harder in order to oxygenate the body, but it's going to be futile. It's not going to really resolve the anemia. If the anemia itself is not treated, then the heart will be forced to work harder. It's going to be fooled like, hey, I think I can do this. I might be able to supply the body with more blood and oxygen. But over time, when the anemia is not treated, this can lead to weakening of the left ventricle as well. Now, again, focus into the word here, systolic dysfunction, heart failure that is with a reduction of ejection fraction. This is what we call as the HFrEF. Okay, so that's the first classification, guys. And take note about the reduction in the ejection fraction of less than 40%. Now let's move on to the next classification here, which is basically the heart failure with preserved ejection fraction, or we call this as the HFpEF. Okay, and this is also going to be called as the diastolic dysfunction type of congestive heart failure. Now, the issue here is not really about the ejection fraction, okay? The problem here is actually with the ventricular filling, which is actually impaired. So with this kind of problem, the heart has trouble relaxing, okay? So that is the reason why the diastolic dysfunction will occur, okay? Trouble in relaxing the chambers or the ventricles, okay? Because this is going to occur in the diastolic phase. Remember about the diastolic phase wherein the heart will relax and it will get ready with a new batch of blood for it to pump into the system. And so with this type of heart failure, it has that impairment. It's not able to really relax. It is going to be so busy and just kind of contracted, okay? And that's why it's not able to really allow enough fill, or it will prevent proper filling of the blood into the ventricles, okay? So this is the key word here, impaired ventricular filling during the diastole, okay? Now, all right, so here we go. Let me just erase this real quick. So the systolic or the diastolic type of heart failure, it's caused by its inability to relax during the diastolic phase. The chambers will become thick and they become stiff as well. All right. Now, on top of that, when we are going to look for the result in the echocardiogram, there will be that appearance that the left ventricle is not relaxing. Okay, it's kind of like contracted. It's not able to relax. Really, this is the main cause. And this is going to be caused by so many factors. It could be caused by the hypertension, maybe myocardial hypertrophy, or it could be caused by the aortic stenosis, mitral stenosis, or the aortic regurgitation. And those are caused by the valvular heart diseases as well. And maybe a restrictive type of cardiomyopathy, which is another disorder that we'll be talking about in the next few days. And so our focus here is to simply understand that with the diastolic heart failure, you need to really recall that the problem here is the inability of the left ventricle to relax, and it will not be able to accommodate that amount of blood to fill during the diastolic phase. So by the time when the heart will pump again, there will be less cardiac output, okay? Again, there will be less cardiac output for the reason that it's not able to accommodate the blood. It's not about the ejection fraction. It's not about the weakening of the muscle, but it is the filling that is not quite able to accommodate the blood, all right? Now let's move on into the test sample right now. Let's go take a look into this test question. So the scenario states, the nurse is caring for a 62-year-old male patient at the ED for increasing shortness of breath with productive cough in the past 3 days. The nurse documented in the ED nurse's notes the following, okay? So it said here at around 9:30 in the morning, June 25th, 2024, admitted patient to bed number 4, alert oriented ×2, disoriented to time and date, Glasgow Coma scale of 14. Vital signs are heart rate irregular, 99 beats per minute, blood pressure of 145/92 mmHg, respirations of 24 cycles per minute, and oral temperature of 99.4 degrees Fahrenheit, 37.4 degrees centigrade, and oxygen saturation of 90% on room air. Initial lab results include BNP of 950 picograms per ml, serum sodium level of 140 milliequivalents per liter, serum potassium level of 3.8 milliequivalents per liter, BUN of 26 milligrams per deciliter, and serum creatinine of 1.4 milligrams per DL. Patient denies any pain or discomfort. Started O2 inhalation via humidified nasal cannula at 2 liters per minute. Placed patient's head of bed at 45 degrees angle and documented by nurse Jane Doe. Okay, so this is what we call as highlighting text, which is actually one of the test types in the next gen NCLEX. I find this very quite easy. All right, easy to capture those abnormal assessment findings. So your role here, or your task, is to highlight the assessment results that are significant for this patient. All right, let me take a look into your answers right now. Okay, let me just wait for a little bit. So I need you to type in those information in the comment section or the chat box, those abnormal findings that will be significant for this patient. Okay. All right. Now, let me go start answering right now. So those test assessment findings, rather, are the following. We have alert oriented ×2. That is a significant finding. It simply means that the patient is not completely or all there. It's not ×3 or ×4. So it said here, disoriented to time and date. That is another one. Okay. That simply means that the patient is disoriented, confused, right? And what else? We also have another abnormal assessment finding, which is GCS of what? 14. The perfect score is 15. So the GCS 14 actually signifies that the patient is disoriented to the time and date. So that is why GCS 14 is there. And of course, we have the irregular heart rate. That is significant. Even though the rate is 99 beats per minute, that is still within the normal range. However, the irregular word there makes it a noticeable abnormal finding. Okay. Now, another thing here is the blood pressure, which is quite elevated. So take a look about the 145/92. That is another abnormal finding. And take a look into the respirations. You have 24 cycles per minute. That is above the normal range of 14 to 20 cycles per minute. Okay. And then we have the oxygen saturation of 90% on room air. That is significantly low. And then we also have the BNP, which is the beta natriuretic peptide of 950 picograms per ml. And take a look into the blood urea nitrogen, guys. Take a look into the number 26. That is elevated, okay? Normally, it should be somewhere between 7 to 20 milligrams per deciliter. And take a look into the serum creatinine, which is 1.4, slightly above the upper limit. All right, 1.4 milligrams per DL is another abnormal finding. And the rest of that is pretty much good. All right. So how many abnormal findings did we capture here? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And in the NCLEX, guys, in the next gen NCLEX, it will probably ask you at least the maximum amount of 10 abnormal findings most of the time. And if you're gonna be selecting or erroneous, if you're highlighting an erroneous phrase or word, that might be deducted, or your total score might be deducted from that erroneous answer. Okay, so please be careful when you are answering highlighting text or highlighting table, because they're quite similar. All right. All right, Jocelyn Diaz, welcome back. I haven't seen you in quite some time. All right, Maria Kugri, thank you for your answers. Very good. All right, we have Nelly Rubio, Ulamuju Esther, welcome. Adiola, Child of Yahweh, Shradra Karel. I'm seeing some new names here in the chat box. Welcome to the class, guys. All right, so what are the significance of those abnormal findings? We'll start with AO times 2, which is basically not a perfect assessment finding. Well, it simply means that these three right here, GCS 14, disoriented to time and date, these are interrelated. Remember about the AO times 3. It actually means that the patient is alert to self or person, alert to time, alert to place. And in some cases, you might see documentation about alert oriented times 4, but it's rarely seen in the NCLEX. But in the clinical practice, we often see the alert oriented times 4. But in the NCLEX, I don't usually see the AO times 4, just the AO times 3. So what does this mean really? AO times 2. Well, it indicates that the patient has altered mental status. And this could be a sign that the patient may have hypoxia. Okay, remember about the sign of hypoxemia. So take a look into the patient's oxygen saturation. About, what was that, 90%? Okay, that is significant right there. And so if the patient is suffering this heart failure for quite some time with chronicity, of course, this can lead to maybe ongoing disorientation, confusion. But for some people as well, if there is that sudden hypoxemia, this probably would be more noticeable by the family members at home. They probably would find the patient, hey, he was alert oriented times 3, or he was like quite with it a few hours ago. Now he's very confused. So that would be so noticeable. But for those patients with chronic hypoxemia because of the congestive heart failure, then probably the patient will be having this disorientation for quite some time, and the family will probably just think, hey, probably he's having some dementia or some sort. And so, yeah, but our goal here in this test question is really to capture those signs of decreased high oxygen level. And this is one example here, which is the disorientation, probably related to the hypoxia or decreased oxygenation to the brain. Now, another is electrolyte imbalances. That could also lead to the confusion, maybe another underlying conditions, but I'm not going to elaborate more on that. Also, the patient here, let's take a look into the respirations. Do we have respiratory rate? Yes, we do. 24 cycles per minute, okay? So in the context of increasing shortness of breath and pulmonary issues, well, hypoxia is a likely cause for this patient, okay? Now let's take a look into the GCS here, 14. Remember about the perfect score, 15. So our patient here has mild impairment in their consciousness, probably, but actually this is not really about the consciousness, but this is more of the disorientation. Now, with the next assessment finding right here, the irregular 99 beats per minute, this can indicate that the patient might have an atrial fibrillation. It's not diagnosed, but could pinpoint to a new problem, which could be atrial fibrillation, or could be from other arrhythmias, which is common, or which are common in some patients with heart failure because of the poor function of the myocardium, because of the chronicity and the poor oxygenation, and also the impaired function of the ventricle. This can also lead to the appearance of the arrhythmias. Okay, now talking about the blood pressure here, where are you? 145/92. It's elevated, guys. So this indicates that the blood pressure, the hypertension, is probably one of the contributing factors why the patient has congestive heart failure. And this can worsen the heart failure if it is not controlled. Again, guys, when your patient has chronic hypertension, this can worsen the heart failure if this is not going to be controlled. So you will probably see patients with congestive heart failure being admitted, they probably would be on so many antihypertensive medications. Okay, now the hypertension itself. Okay, let's talk about the hypertension right now. Remember about the systemic vascular resistance. Okay, SVR, systemic vascular resistance, actually can worsen CHF, right? And when this happens, you know about the backflow, right? Especially in the left-sided heart failure, when the left ventricle is no longer able to pump effectively the blood, it will now complicate into the backflow of the blood into the pulmonary circulation. And then it will manifest with so many things: shortness of breath. There will be decreased oxygen level. There's also going to be crackles, wheezing. And this simply means that there is now consolidation of fluids in the pulmonary circulation, or it could be shifting of fluids from the capillaries into the alveoli. And so there will be a compromise in the exchange of gases. All right. Now, talking about the respirations of 24. Yeah, that's easy to spot right there. Tachypnea, that is the term that we call that. It's the rapid breathing. And it could mean that there is respiratory distress, or this is a compensation to the low oxygen level. Because of the 90% oxygen saturation, the body will trigger the lungs to work harder, to breathe faster in order to attempt in replenishing the body of oxygen and the blood supply. Okay. Now, another thing here is the BNP of 950 picograms per ml. What is that? Remember about the BNP. This is a peptide. This is a hormone that is normally produced by the heart, the ventricle. And this is going to be released. It will be elevated when there is fluid volume overload. Okay, we're talking about the BNP. This is a hormone that is released when during fluid overload in the circulation. Of course, every fluid will come back to the heart, right? For it to go back in, or for it to be reoxygenated into the lungs. And so once the body will sense, or once the heart will sense that there is too much fluid that it has to accommodate, the BNP will be released into the circulation. Simply means that, hey, I'm just letting you know that we are so overloaded right now. This is my trigger that you need to excrete the excess fluid through the urination. Okay, so the BNP basically is a trigger mechanism in order to have the kidneys excrete the excess fluids. However, in this scenario, it's no longer effective. Okay, it's only gonna increase in value if there is fluid volume overload. However, it will not be effective in causing the diuresis. It will not be effective in causing the excretion of sodium ions in the blood. Okay, because supposedly that is the role of the BNP. Let me write that down. It's no longer effective. The BNP is going to, supposedly, it's supposed to trigger diuresis or excretion of excess fluids, and the other one is natriuresis, which is the excretion of excess sodium ions from the bloodstream. But it's no longer going to be effective, guys. Okay, so have you seen your patients back in the clinicals when they have BNP levels up to like 2,000, 3,000 picograms per ml? Have you seen those? Yeah, because I have seen even 6,000 or even 9,000 for those really severe type of congestive heart failure. And so the body's really signaling that, hey, I have got way too much fluid in the body, and this is my trigger. to allow the excretion, but the body will not be able to successfully do that anymore. Okay, another lab value, we have the BUN of 26 and creatinine of 1.4. These are abnormal values and indicates potential renal impairment. Also possibly decrease in the renal perfusion. Remember about the concept that I talk about in the renal topics? Remember about the congestive heart failure as one of the causes for the renal failure. Because remember that with, let me just write this down real quick. In the case of CHF, what's going to happen is that the cardiac output will be decreased, okay? When that happens, the blood pressure will also be decreased. And remember that the kidneys are supposed to receive about 20% of the total cardiac output. But when there is a prolonged hypotension, the blood pressure probably hangs around the 90s, 80s systolic. Over time, this can lead to impairment in the kidney function. Okay, renal failure. Okay, I'm just simplifying here. All right, when there is congestive heart failure, the cardiac output will be decreased. It will also decrease the blood pressure. So it simply means that the oxygenation, the blood supply to the major organs, including the kidneys, will also be impaired. And this can do a lot of bad things to the kidneys. It will lead to renal failure. And then you will see those BUN and creatinine going up. Maybe the glomerular filtration rate will also be going up. It simply means that there is now impairment in the kidney function. All right, so enough for this slide. We got to move forward with the next test question, guys. Let's take a look into the temperature. 99.4 degrees Fahrenheit, 37.4. Yes, it is normal. In our cutoff here, especially if you're used to the centigrade, our cutoff is 37.7. Anything above that is already considered fever, okay? For the Fahrenheit, anything above 100 is already considered abnormal, okay? For the Fahrenheit, anything above 100. For the Celsius or centigrade, anything above 37.7, all right? But don't get confused, guys, because some of the nurses refer 99.4 as low-grade fever, but don't let that confuse you, because that would really affect your analysis. So anything above 100 degrees Fahrenheit or above 37.7 degrees Celsius, that's considered fever, okay? Do not get confused with a low-grade temperature or low-grade fever like what they say. And I've always heard that back in the acute care. All right. Now, let's move on to the next question, guys. Number 2. The nurse is caring for a 62-year-old male patient at the emergency room department for increasing shortness of breath with productive cough in the past 3 days. The nurse suspects that the patient's pulmonary edema was caused by the heart failure. For each clinical features below, click to specify if the manifestation is either a sign of right-sided heart failure or left-sided heart failure. Okay, so that is your task. Again, let's take a look into the scenario here. It's stated the nurse is caring for a 62-year-old male patient at the emergency room department for increasing shortness of breath with productive cough in the past 3 days. The nurse documented in the ED nurse's notes the following. Hang on a sec. Actually, guys, we don't have that information about the documentation, but for this test item, what I'm going to need you to do is basically identify if these assessment findings belong to either the right-sided heart failure or is it going to be under the left-sided heart failure category. Okay. All righty. I'm going to need to check your answers right now. So what about orthopnea? What do you think about that one? Orthopnea. Orthopnea basically is the difficulty of breathing when the patient is in a flat position, lying flat position, and the patient will definitely need to sit up right and probably will end up leaning forward on a table in order to catch their breath. So what do you think about the orthopnea? Does it belong under the right-sided heart failure, or is it in the left-sided heart failure? Okay, I'm not quite sure if there was too much delay in our live, but I'm not quite sure what's going on here. All right, I'm seeing right side, right ventricular heave, JVD, peripheral pitting edema. Okay. Mary answered both for the orthopnea. Right. Okay. Orthopnea. Orthopnea is actually a pulmonary manifestation, right? It's a respiratory manifestation. And this is commonly an assessment, a common assessment finding in left-sided heart failure. Okay, don't ever forget that, guys. Orthopnea is not seen in the right-sided heart failure. There's not a lot of involvement in the lungs, okay? Now let's take a look into the paroxysmal nocturnal dyspnea. We call that as the PND, okay? PND, paroxysmal nocturnal dyspnea. What is that? Well, this is basically the sudden shortness of breath that will awaken the person from sleep. It happens when they are in deep sleep, and usually it will occur in about 1 to 2 hours after going to bed. So they already kind of settled in bed, probably had started in their first or second stage of sleep, and all of a sudden they get awakened because of the shortness of breath. And so this is another respiratory manifestation. We're going to assign this to the left-sided heart failure. Now, what is the reason why the patient is manifesting the paroxysmal nocturnal dyspnea? Well, the reason for that, it's because of the redistribution. Redistribution of what? The fluid from the legs. From the bilateral lower extremities, okay? And then it will be going back into the pulmonary circulation, and that is why it will be overwhelmed, and this will cause the person to wake up immediately, okay? It will cause congestion in the pulmonary circulation, okay? All right. And most of the time, guys, when a person has the CHF during the daytime, of course, they're just going to be sitting on the recliner or maybe on the chair the whole day. They might go to bed maybe for a good 2 hours, and then they will sit again on the recliner for the rest of the afternoon before they, and then they're going to take their dinner. So by the time when they go back to bed, the fluids that have been circulating poorly in the vascular system, once the patient assumes lying position in bed, this will now overwhelm the pulmonary circulation, and that's why they're going to end up with a PND, okay? Now, let's talk about the nocturnal dyspnea. What is this? Of course, it's going to happen at nighttime. It's also going to be assigned under the left-sided heart failure. And of course, this is also the result of pulmonary congestion caused by the fluid buildup in the lungs, again, caused by the left-sided heart failure, okay? Now, take a look into the next manifestation here, confusion. Remember about the patient that we had in our first slide? Disoriented to time and date, okay? So the confusion can occur in the left-sided heart failure because of the decreased tissue perfusion. due to decreased tissue perfusion. Okay? And why there is decreased tissue perfusion? Remember about the reduction in the cardiac output? The same reason. Decreased cardiac output from the left side of the heart. All right? So when there is poor or there is decreased cardiac output, the blood supply to the brain is also compromised. Lack of oxygen. Okay? Now let's talk about another manifestation here. What about the nocturia? What is nocturia? Well, nocturia is basically the excessive urination at night. And this is going to occur in a person with the right-sided heart failure. Why? The reason for that, it's because during the day, remember about the right-sided heart failure. Let me just write it down here. Right-sided heart failure. And going back into the avocado heart right now. Did you miss the avocado today? Okay. Remember about the right-sided heart failure. The congestion in the right ventricle, the dilation, the weakening of the right ventricle will cause the blood to backflow into the right atrium. It will backflow into the superior vena cava and also the inferior vena cava. It will be congested there. There is going to be heavy traffic of blood in the venous system. And remember about that, it will lead into the edema, right? So when the person is awake during the daytime, of course, they're not going to be doing a whole lot of activities because they just get so tired. They have edema in the lower extremities. So most of the time, they're just going to sit on the recliner or the chair, just kind of watching TV. And by the time when they're going to go back to bed, when their legs are quite like the same level with the heart or the head of the bed, then this is the time that the fluids will get reabsorbed into the circulation, and then it will be excreted by the kidneys. And that's unfortunate because the reabsorption will happen in the evening when they're actually in bed. So they will be bothered by going to the bathroom, probably just urinating at the side of their bed. They're going to use a urinal, so they will get up most of the time at nighttime. Okay, so this is related to the right-sided heart failure. Okay, so I hope that you're able to understand that explanation. Now let's go forward here with our next manifestation. Displaced PMI. What is the PMI? I hope that you still recall the fundamentals of our cardiovascular system. What is the PMI? That pertains to the point of maximum impulse. This is where you're supposed to be assessing the apical rate. You can accurately assess the apical heart rate in this part of your intercostal space, usually between the fourth and the fifth intercostal space. That is the normal. However, the PMI will be displaced. It simply means that there is the site of the PMI is no longer there. It will go further below the fifth intercostal space. Why? The reason for that, it's because of the ventricular enlargement. Because of the congestive heart failure, or because of the enlargement, the ventricles will go down further. Okay, it's dilated. And so when you are listening for the PMI, it's no longer between the fourth and the fifth ICS. You'll be hearing it much lower than that level. Okay, so that is why we call it as displaced PMI. Now, where should we assign the PMI here, or the displaced PMI? Is this going to be to the left sided heart failure? Good morning, Barad. So the displaced PMI is going to be assigned to what? The left-sided heart failure. And the reason because of the left ventricular hypertrophy. That's one reason. Left ventricular hypertrophy, or could be due to dilation of the left ventricle. Okay, so again, the PMI that is supposed to be between 4 to 5th, between 4 and 5th ICS is no longer there. It is going to be auscultated louder below that. Okay, now moving to the next manifestation here, S3 gallop. What is this? S3 gallop is an extra abnormal heart sound. Okay, we're supposed to have S1 and S2 only, but here our patient with a CHF is going to have the S3. Now, what is the S3 first? This is actually an indication that there is increased blood volume in the ventricle. Okay, let me find my pen. Increased blood volume in the left ventricle. That is why the S3 will be auscultated. Okay, so if your patient has fluid volume overload, maybe because of so many factors aside from the congestive heart failure, probably they're taking in way too much sodium and not really following the doctor's order in the fluid restriction, and so they're going to be overwhelmed with the fluid inside the bloodstream. And so this is going to be assigned into the left-sided heart failure column. Okay, all right, let me erase that. We're going to assign the S3 to the left-sided heart failure. Now, what about the S4? The S4 is another extra abnormal heart sound, and this is caused by the resistance of the resistance to ventricular filling. Okay, so why there is resistance? Maybe because the patient's heart has what we call as hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Or maybe there is left ventricular hypertrophy. Okay, again, pertaining to the left side of the heart. So, of course, we're going to run out of space here for the left side. Just kidding. So, S4 gallop, again, is caused by the resistance to ventricular filling. The blood is not going to really fill the left ventricle around this time because it fails to relax. Remember about what I said earlier about the diastolic dysfunction? And again, the specific cause here is hypertrophic cardiomyopathy, or it could be left ventricular hypertrophy. So let me get rid of this. We are assigning the S4 to the left-sided heart failure. Now, what about the right ventricular heave? What is right ventricular heave? This is basically a lift. The patient will feel, or actually you can feel that the chest is somewhat kind of moving forwards when you are palpating, and this is going to be appreciated or will be noticed more to the left sternal border. Okay, so this is going to be felt in the left sternal border. Okay, but it doesn't mean that we're talking about the left ventricle this time. The lift will be assessed onto the lower left sternal border, and this is going to be associated to the right-sided heart failure. Now, what is the cause of the right ventricular heave? The cause for that is the pulmonary hypertension. Pulmonary hypertension, HTN. Remember about that pulmonary hypertension lecture that I did? Let me create a space. All right. Switching to the pen. Here's another avocado. Remember about the pulmonary hypertension? There is increased pressure in the pulmonary artery. Okay. So basically, if you want to recall really the path of the blood in the heart chambers, remember that the blood enters into the right atrium, right? It goes to the right ventricle, and also it will go to the pulmonary artery, and then it goes to the lungs. It goes back to the heart via the pulmonary veins, and it will go enter the left atrium. Now, the problem here is in the pulmonary artery. The pressure in there is high. And remember about one of the causes of pulmonary hypertension? COPD, such as emphysema. Okay. So this is going to lead into the right-sided heart failure, and this is what we call as the cor pulmonale. Remember about that? The cor pulmonale basically is the right-sided heart failure, and this is often caused by the hypertension within the pulmonary circulation, and this is a complication brought about by COPD emphysema. Okay, so the right ventricle heave here is going to be assigned to, because the heart is on the left, most boredom take place on the left. Okay. Yeah, but when we are talking about the right ventricular heave, this is basically caused by the pulmonary hypertension, which is towards the right side of the heart. Okay, I don't know if patients typed in your answer. Probably you are not really with the same time frame that we are at right now. Maybe you just started watching the live. So, okay, let me erase that real quick. And so here, our right ventricular heave is going to be assigned to the right side of the heart. And dullness on chest percussion. Dullness. What do you think about the dullness here? Is this going to be the right-sided or left-sided heart failure? Well, again, another pulmonary manifestation. So this simply means that the patient might be developing pleural effusion, or maybe the patient is developing pulmonary edema. Of course, the consolidation of fluids into the lungs, the alveoli. What do you think about that? All pulmonary manifestations. This is going to be assigned to the left-sided heart failure. Okay, what about the JVD positive? The jugular venous distension. Okay, that's easy to spot. This is in the venous circulation, so this will be assigned to the right-sided heart failure. Now, what about the peripheral pitting edema? Another problem in the venous circulation. So that will be assigned to the right-sided heart failure. Okay? Right-sided heart failure. Yeah, I'm noticing that patients is answering left more often right now, but I guess she's just starting to watch the video, so I don't think that she is in the same pace right now. So yeah, just want to make sure. Okay, so in review, guys, let's take a look into the different manifestations. Okay, when you are going to see the patient developing pulmonary manifestations, you're going to have to associate that with the left-sided heart failure. Orthopnea, paroxysmal nocturnal dyspnea, nocturnal cough. There's also dullness in the chest percussion. There's also that confusion, nocturnal cough. And on top of that, we got the abnormal heart sounds as well, the S3 and the S4. and the displaced point of maximum impulse because of the dilation of the left ventricle. Now, if you're going to be recalling those manifestations on the right-sided heart failure, what you're going to think about is venous circulation congestion. Venous congestion. So we are talking about edema in the lower extremities and also JVD, and the patient probably will develop one of those complications, hepatomegaly, because of the backflow, the regurgitation, and ascites, edema. Okay, let me just write everything here. JVD. Okay, that's for the right-sided heart failure. All righty. Now let's move on to the next question. Now we're going to have to go back into the assessment findings here. Just want to make sure that you're able to capture all these so you don't get confused. So our assessment findings in the left-sided heart failure, again, will include the dyspnea, which is basically the impairment in the function of the left side of the heart. It will cause backflow into the pulmonary circulation, the orthopnea, the paroxysmal nocturnal dyspnea, nocturnal cough. There will be confusion, diaphoresis, and the reason why the patient will end up with a diaphoresis is because of the body's response to the stress. Okay, and it will activate the sympathetic nervous system. All right, activation of the sympathetic nervous system, and that's why they're going to end up with the excessive sweating or diaphoresis. Now, don't forget about the displaced point of maximum impulse, and this is because of the enlargement of the left ventricle. Okay, due to enlargement of the left ventricle. Now, we also have the pathologic heart sounds. Let me just erase this real quick. These are your ventricular gallop, S3. And then we also have the S4 gallop, and this is because of the resistance to the filling phase. That's why there is the S4, okay? And we also have the, what? The crackles or rails on the basis. Again, we are talking about the left-sided heart failure, guys. And what is the reason for the crackles? This is because of the increased hydrostatic pressure in the pulmonary capillaries. Increased hydrostatic pressure in the pulmonary capillaries. Pulmonary capillaries. And this will now cause the shifting of the fluids from the capillaries into the alveoli. And so the alveoli now will be filled with the fluids, right? So that's why you're going to hear those rails and crackles. Another will be the dullness to percussion because of the consolidation. You're not going to hear much of the resonance here. Now, we're talking about this time on the right-sided heart failure. Just to recap, the right-sided heart failure manifestations will include the peripheral pitting edema, nocturia, the jugular venous distension, and possibly the hepatomegaly or the hepatojugular reflux. This is going to be assessed when you are going to put the patient in bed, and when you are going to press the liver into the right upper quadrant. Okay, so when the patient is in like a 30 degrees angle when you're assessing the patient in bed, you're going to have to palpate the liver. And once you palpate the liver in the right upper quadrant, once you do the palpation to the right upper quadrant, just gently palpating, this will cause the distension of the jugular vein. Okay, so you will see the vein here, the extra jugular vein will be distended when you press the right upper quadrant where the liver resides. Okay, so this is what we call as the hepatojugular reflux. Now, another manifestation here, guys, is the ascites, which is going to be caused by the increasing pressure in the veins in the abdomen. This is what we call as portal hypertension. And this is another complication of the right-sided heart failure. Okay. Now, we are not done yet. Let me just erase this real quick. Aside from the ascites, there will be that right ventricular heave, which is common in a patient with what? Pulmonary hypertension. Okay. And this will lead into the right-sided heart failure. Okay. And remember that when the patient will have that abnormal lift into their chest, it actually bounces back, and this is attributed to the right-sided heart failure. Okay. All right. Let's move forward with our next section of the topic here. We'll talk just slightly about the diagnostic test. So you are probably familiar with some of these, but we'll just go over real quick here. And so one of the diagnostic tests that will be utilized in the diagnosis is the chest X-ray. And what the doctor will often see in the chest X-ray is the cardiomegaly. That is one of the findings that will be seen. There will be cardiomegaly. There's enlargement of the heart tissue. Of course, another is the prominent interstitial markings. What is this? Prominent interstitial markings. So this simply means that there will be some lines that will be obviously going to be seen in the X-ray, that you're actually going to see the fluid building up in the lung tissue. So let me zoom this right here. Can you see those lines that actually would give you an idea that the blood vessels in the lungs are kind of like dilated? Do you see those like lines or outlines of the blood vessels? Are you seeing that in the X-ray? Those are what we call as the prominent interstitial markings. So there is now fluid buildup in the lung tissue. And again, this signals that the patient has the congestive heart failure. Now, another finding that you probably will see in the chest X-ray is the pleural effusion. All right. So this is now the presence of the excess fluid in around the lungs, and this is going to be detected by the chest X-ray as well. Now let's take a look into the echocardiogram. Let me just delete that real quick. So the echocardiogram will do a lot of stuff. It can give us a better idea of the size of the heart. It can also identify the causes, why the heart valves are not working, or probably it will also help determine if the heart failure is caused by systolic dysfunction, or it could be diastolic dysfunction. And it will also help us in determining the ejection fraction, EF. Okay. Now moving on forward here, we also have the BNP, the beta natriuretic peptide. Remember about the value here? The BNP normally is less than 100 picograms per ml. Okay. However, if there is elevation greater than 100 picograms per ml, this signifies that the patient has decompensated heart failure. So it simply means that there is worsening of the patient's HF. And we also have a new assay here, which is the NT-proBNP. So what is this? This is a new laboratory testing that will also help in determining that there is an ongoing heart failure. So the value here is going to be greater than 300 picograms per ml. So this will also help in the diagnosis of a decompensated heart failure. It simply means that there is worsening of the heart failure. All right. Now, you got to be careful though with the NT-proBNP, because this is going to give a false positive. This is going to actually not false positive, but this is going to give us a false low reading in obese individuals. Okay. False low NT-proBNP in obese patients. So this will not become a reliable diagnostic test. So it will require another testing in order to confirm the patient's congestive heart failure. Okay. Now another is EKG. What's the significance of the EKG here? Well, it can be used, but it will be non-specific, but it will also be helpful in determining the enlargement of the chamber, okay, or especially if there is ischemia. Now, we're going to talk about the cardiac catheterization just superficially, because we have already discussed this in the past few days. The cardiac catheterization is going to give us the information about the filling pressures inside the heart, and it will also clarify the diagnosis. It will give us a better, precise information about the heart's function, and it will also check for any coronary artery disease as a main causative factor for the congestive heart failure. Now, another diagnostic test here is the stress testing. Okay, so it will identify those areas of the heart not getting enough blood because of the blocked arteries. It will also help determine how the heart is performing, especially under stress, and the overall stress level. Now, the stress testing is also going to help distinguish whether the shortness of breath is caused by a heart issue, or maybe the shortness of breath is caused by the lung problem. And the stress testing will also help monitor in the heart rhythm, the heart rate, and also the blood pressure during the diagnostic procedure. Okay, so that's all about the diagnostic test. Let's talk about the treatment before we go to the next set of questions. Guys, we're going to talk first about the treatment of the systolic dysfunction, the HFrEF, the heart failure with reduced ejection fraction. So what would be included here? Okay, so this will involve lifestyle modification. So it will comprise dietary modification, including fluid intake. And so these are the following. What will be that? Well, there will be sodium restriction. And so in some cases, the medical provider will probably order 4 grams per day, okay, restriction, or maybe 2 grams, less than 2 grams per day. It will be dependent, or it will be varied according to the patient's overall status, okay? Now, we're also gonna include here the fluid restriction, which is going to be important. And during the acute phase, this is gonna be helpful in order to help manage the shortness of breathing. So expect that our patient probably will have a less allowed water intake. Okay, so this is probably going to be around 1.5 liters or probably 2 liters per day. Okay. Or maybe even lesser to this amount. Okay. It depends on the severity of the manifestations. Some of these patients probably will only be allowed to 1 liter per day. So yeah, it can be varied as well. Now, another lifestyle modification that we will be expecting here is the promotion of weight loss, because when the patient will have this remarkable weight loss, maybe because of the dietary modification or exercise, this can also decrease the workload of the heart. Now, another modification here is to include some smoking cessation, because this will also include, this will help in the overall heart health. It will decrease the vasoconstriction. It will prevent that. Now, alcohol use restriction will also be included if the patient is a drinker or a chronic alcoholic abuser. This will also prevent the additional strain into the heart tissue. Now, aside from the alcohol restriction, exercise is going to be allowed at some degree. Regular physical activity will also improve the cardiovascular fitness. But we are not talking here about excessive, strenuous type of exercise. No, that would not be beneficial for the patient. We just want to make sure that there is constant, tolerated, appropriate level of activity for this patient with a CHF. Now, talking about daily weight monitoring, this is another crucial treatment wherein the patient will have to monitor their own weight at home using the same scale. Make sure that they're also reporting any significant increase in their weight in order to detect fluid retention daily. So for example, a significant retention is going to be greater than 2 pounds per day. That is significant, guys. Or this is like 0.9 kilogram per day. And they need to report that to the medical provider once they have a significant elevation or gaining of the weight. Now, another is annual pneumococcal and influenza vaccination, because when the patient will experience some sort of respiratory infection, flu during the flu season, or pneumonia, this can also overwhelm the cardiovascular system and it will exacerbate the congestive heart failure. And so this is another preventive measure. Okay. Now, another treatment here is all about diuretics. And the diuretics are actually one of the modalities that will be effective in providing symptomatic relief, especially when they get the fluid volume overload in their lungs, pulmonary edema, crackles. We definitely need to include this in their therapy, okay, as needed. Now, also, the diuretics is going to be recommended for those patients with the systolic dysfunction. All right, remember about the decreased ejection fraction. Now, in the recent studies, guys, unfortunately, the diuretics have not been shown to have really not shown to reduce the mortality or to improve the diagnosis of the patient. That is the sad part about it. But for some, at some degree, though, it still kind of helps out, at least to treat the patient symptomatically when they get overwhelmed with excess fluid. But again, it doesn't really reduce the mortality. It's just kind of prolonging the patient's lifespan. Now, we're going to talk about here on the loop diuretics. So for example, if your patient develops pulmonary edema in the acute care setting, and probably this is going to be the reason why they get admitted to the hospital, because they cannot breathe. They just feel like they're dying anytime sooner. And so when the patient's CHF is exacerbated, then they're going to end up with this critical condition, pulmonary edema. There is that fluid volume excess in the circulation and also the lungs. And I mentioned this quite a few times already, that you're going to have to treat this patient with a pulmonary edema with the use of the loop diuretic Lasix. It will really save the patient, guys, especially if you're going to give this IV. The onset of the medication will be around 5 to 10 minutes, and it could last for several hours. Okay, so the drug of choice to relieve or to treat the patient's pulmonary edema during the acute phase is the use of the loop diuretic Lasix. Okay, now another classification of diuretics that might be incorporated in the treatment plan of the patient will be the thiazide diuretics. And the reason for that is we're going to promote excretion of extra fluids and also excretion of sodium. We want to get rid of the excess fluids and sodium. Same thing with the Lasix. It will get rid of excess water, excess sodium, and most of the electrolytes will also be excreted via the urine. Okay. Now we will be talking about the other therapies. Aside from the diuretics, there will be the incorporation of the ACE inhibitor, which is very helpful, guys. The effect of the ACE inhibitors, which we refer to as the angiotensin converting enzyme inhibitors, this is going to help relax the blood vessels. Blood vessels, resulting vasodilation. And this will also reduce the heart's workload. Reduces heart workload because the systemic vascular resistance is decreased, right? Decreased SVR because of that vasodilation. Do you still recall that concept about the afterload? If you still do, good for you, because this is very important, guys. When there is an administration of the ACE inhibitors, this will also decrease the afterload, which is basically the amount of pressure that the left ventricle will need to overcome. And so when there is decreased vascular resistance, then the heart will not pump harder this time. Okay. Now, another set of classification here will be the, before I forget, before we go forward to the ARBs, what are the side effects that you recall when the patient takes the ACE inhibitors? What can you recall here? All right. Are you still there, guys? Are you still hanging out with me? The chat box is really quiet today. Now, one of those side effects here is the dry cough. This is one of the side effects that will cause the patient to dislike taking the medication. They just don't want to experience the dry cough, which is very annoying. This just can come out of nowhere while they are doing their daily activities. They probably would just have that cough attack all of a sudden. This is dry. And the reason for the dry cough is basically there is now a buildup in the bradykinin, increased bradykinin, which is one of the chemical mediators. Once there is now an increase in the bradykinin in the bloodstream, this will now irritate the cough receptors. That is why they're going to end up with the dry cough. That is because of the increased level of the bradykinin. Because, guys, supposedly in the normal function, the ACE, the angiotensin converting enzyme, is supposed to break down the bradykinin. Okay, that is the effect of the angiotensin converting enzyme, the ACE. However, when the patient takes the ACE inhibitor, that breakdown will no longer be there. And so there is that increased level of the bradykinin in the blood. And again, it will irritate the cough receptors. And so the patient will be complaining about the dry cough. Okay? All right. So I hope that you're capturing that one. Let me erase this section because I have more stuff to write. Okay. All righty. Aside from the dry cough, one of the most common side effects here is the orthostatic hypotension. And this is probably going to come out in the exam, especially if you are treating an elderly person. Orthostatic hypotension. That's another side effect. So when the patient gets up, they're going to end up dizzy, right? Or get lightheaded. And you've got to be careful in taking care of this patient, especially if this is going to be their first time taking this medication, because they're going to be prone to falling. Your patient will be definitely a fall risk. Okay? We don't want this happening on our patient. So another safety issue when we are dealing with this medication. So you got to be careful, make sure that you're attending to this patient when they get out of bed, and possibly activating the bed alarm when they get up, because they probably would not use the call bell because they're confused, they're forgetful. So make sure that you activate the bed alarm if you're dealing with a confused, disoriented patient. Now, another side effect in the use of ACE inhibitor is what? Hyperkalemia. Excess potassium ions greater than 5.0. Okay? Excess potassium. The reason for the hyperkalemia, yeah, that's correct, Mary. So what you're going to do, instruct to your patient with a known orthostatic hypotension, you're going to have to instruct them to move slowly, have them sit to the edge of the bed first, and have their legs dangle, kind of touch the floor as well, wiggle their toes, and then wait for a good 5 to 10 minutes, and then they're going to be assisted to stand up. Okay, so that's about orthostatic hypertension. Now, talking about the hyperkalemia. The reason that there is hyperkalemia when the person takes the ACE inhibitor, because when the patient uses the ACE inhibitors, it will what? Suppress the aldosterone. It suppresses aldosterone. Remember, guys, that the aldosterone is the regulator of potassium. Okay, let me write it here. Aldosterone is the regulator of potassium in the body. And so if there is suppression of the aldosterone, who's going to regulate the potassium this time? Nobody will regulate. And so there will be retention of the potassium ions in the blood because of the suppression of the aldosterone. Remember about that concept that I presented in the renal disorders? So what page are we at right now? We are in page 487. Okay, let me just write that down so I have a reminder, because I'm going to switch the window. 487. So let's revisit that concept in the renal system. All right. Here we go. Okay. Homeostasis, pH, potassium. Okay, so remember about the potassium homeostasis. when the patient ends up with hyperkalemia. This is about the normal physiology here. Okay. In the normal physiology, when the patient's potassium level gets higher or exceeding 5 milliequivalents per liter, what's going to happen is that it will trigger the release of the aldosterone. Triggers aldosterone. And once the aldosterone is released into the bloodstream, it will now cause the excretion of the potassium ions by the principal cells in the collecting ducts. Okay? And when this is happening, this will now lead into the normalization or restoration of the normal serum potassium, because the kidneys are actually excreting the excess potassium ions. And again, what controls it? The aldosterone. Now, if in a case wherein there is hypokalemia, a drop of the potassium level, what's going to happen here? Well, the body will not really cause the secretion of the aldosterone this time. There is no need because the potassium is low. And when that happens, the kidney tubules will now try reabsorbing those potassium ions in the collecting tubules. And this will now help restore the normal amount of the potassium ions in the bloodstream. Okay, so that is very simple to recall about the regulation of the potassium. Again, the regulator is what? Aldosterone. Now, like I have said, when the patient takes the ACE inhibitor, remember that the ACE inhibitor will suppress the release of aldosterone. Okay, where are we at? Let me figure where that page is. Yeah. So the ACE inhibitor will suppress the secretion of the aldosterone, so there's no longer regulation of the potassium ions. That's why it's going to cause the hyperkalemia. All right. There are some more side effects here, so let me just quickly finish this. So let me re-enumerate those again. Dry cough. There's also the what? Orthostatic let me just put low blood pressure, orthostatic hypotension. There's also going to be dysfunction in the kidney. So you got to watch out for the creatinine level, guys. Dysfunction of the kidney. And another thing is that it can lead into angioedema. Have you seen a patient with this one in the real setting? This is a rare but a serious side effect of the ACE inhibitor, and I have seen this in my own practice. It's quite scary. When you're gonna instruct the patient to stick out their tongue like that, normally the tongue is kind of flattened, right? It's a muscle, but it will flatten when they're sticking it out, right? But when you're going to ask the patient to stick the tongue out with angioedema, well, it's a muscle, right? It is going to be really fat. Yeah, and it's quite scary because it can obstruct the airway as well. And this is one of the complications in one of the patients that I admitted with a new prescription for the ACE inhibitor. Yeah, it's quite interesting. And so aside from the angioedema, it can also cause some swelling in the face, facial swelling. Also the throat, and in some cases the intestines as well. So you got to watch out for this life-threatening side effect, angioedema. And in some cases, the patient probably will develop rashes or skin reactions. It can cause itching. Maybe it can also lead to much more severe skin rash. Okay. Now, another side effect here, guys, don't neglect that the ACE inhibitors can also cause metallic taste. But this is going to be temporary. This can occur in about 1 to 4 weeks. It will go away. And this is what we call as what? Dysgeusia. Altered taste. Okay. And again, you're going to have to tell the patient this is a temporary side effect that will go away in about 1 to 4 weeks. So they're going to have that altered sensation or altered taste, metallic taste, or maybe a lack of taste in their food. Okay. So it is expected that their food intake probably would be diminished around that time. Now, moving forward here, aside from the ACE inhibitors, there will be a possibility that the patient might end up getting the angiotensin receptor blockers. And we have the examples here like valsartan or losartan. So those sartan medications, okay, sartans, these are medications that fall under the angiotensin receptor blockers. So this is going to be the alternative to the ACE inhibitors. And again, the reason that they're gonna dislike the ACE inhibitors, it's because of the what? Dry cough. Okay, again, it's a dry cough that makes him dislike the ACE inhibitor. So most of the times the medical provider will switch them into the ARBs. Now, aside from the ARBs, there will be the inclusion probably on the beta blockers. So recall the metoprolol, the olol medications, carvedilol, bisoprolol, and I'm not going to elaborate more on that. There's probably going to be an inclusion of the aldosterone antagonists, and these are your potassium sparing diuretics. So again, the spironolactone will be included here, or known as the aldactone. This is going to conserve K ions, but will excrete water and sodium. So usually the spironolactone will be helpful for those patients that may end up with hypokalemia caused by the prolonged use of the loop diuretics. And so the spironolactone will kind of help even out the level, the potassium in the bloodstream to prevent the hypokalemia. Okay. Now, this is going to be recommended. Okay, the spironolactone is recommended for those patients with an ejection fraction of less than 35%. Okay, so this is going to help reduce the fluid retention. Remember about the EF that is less than 40%. They're not going to be able to pump the blood into the circulation. And so they definitely need to maintain taking this diuretic medication. Okay. Now let's move forward with the next treatment modality here. We have the AICD implantation. So what is this? This is going to be that electronic device that will be implanted under the skin, just like a, what do you call this? A pacemaker. So this is what we call as the AICD, which stands for the automatic implantable cardioverter defibrillator. And so this is going to help the patient to avert from any sudden cardiac death. Okay, this will prevent, let me just put here, prevent sudden cardiac death. All right. So that is the importance of having that automatic implantable cardioverter defibrillator. So another medication, we are not done yet. There's more. Another is hydralazine. So hydralazine is another medication intended to treat the hypertension, because when the patient has hypertension, it can also worsen the congestive heart failure. So we want to make sure that the patient's blood pressure is maintained on a safe range. Okay. So aside from the hydralazine use, there could be the prescription, which is quite a new medication right here. We have the sacubitril valsartan, which is the ARNI. This is a new classification. I don't know if you're familiar with this classification, but this is basically what we refer to as the angiotensin receptor, angiotensin receptor neprilysin inhibitor. So basically it will do quite similar with the ACE inhibitor. It can lead into the vasodilation, decreasing systemic vascular resistance, and will decrease the ventricular workload. Okay, and the sacubitril is going to be recommended for those patients with ejection fraction less than 35%. Okay, so this is going to really help improve and decrease mortality in the patient. Okay, decrease mortality because of that effective therapeutic effect. All right. Now, aside from the sacubitril or valsartan or ARNI, we also have that digoxin. Guys, I'm actually looking into the evidence-based practices, right? Like new literatures, researches. And so we know that digoxin is really helpful in the treatment, right? Don't forget about the different effects. Positive inotropic effect, which is going to improve the contraction or the contractility. Let me rewrite that. There is improvement in the contraction of the heart muscle. It will strengthen the force of the contraction. Let me just put it that way. Increase force of heart contraction. There is also that decrease chronotropic effect, which is basically gonna slow down the heart rate. It also has that decrease dromotropic effect, which is going to slow down the impulses, electrical impulses from the AV node. From the AV node. So I know the benefits here, guys. It will also increase the cardiac output. All right. It will be helpful in increasing the cardiac output of our patient with a CHF. However, when I read into the recent studies about the effectiveness of the digoxin, this was considered to be once regularly used for HFrEF. Okay. But recently, it hasn't been shown to improve really the mortality in the ventricular chamber. So, yeah, that's quite sad. But it's still being used in the acute care setting, guys. Don't worry about it. But just reading into the newer studies that it's not really giving us the therapeutic effects that we expected it to have. All right. Now, guys, you might be asking the NCLEX question regarding the therapeutic level of the digoxin. So don't be forgetful about the level. The level of the digoxin is somewhere from 0.5 to 2 nanograms per ml. Okay, that is the safe range, therapeutic level of digoxin. Anything above that, let's say 2.2 or greater, the patient is prone to developing digoxin toxicity. Okay, excess will lead to digoxin toxicity. And if it's less than 0.5, well, it is subtherapeutic level. It will not work for the patient if the level is still low. Now, guys, you might see this in the NCLEX that the doctor might order a loading dose, which is going to be a higher than normal dose for this patient. And the reason that the loading dose will be ordered for this patient is to achieve rapid therapeutic effect for this patient. Okay. Let me rewrite that somewhere. Again, about the loading dose. So if in case the patient has an exacerbation of the congestive heart failure, and if their digoxin level is not in the therapeutic range, the doctor will end up ordering the loading dose of digoxin. And again, the reason for that is to achieve the therapeutic level in a much faster fashion. Okay, so you don't have to, I mean, the order will really state there that we are giving the loading dose of the digoxin. So it will be bigger than the usual dose. Okay, so this is not like an erroneous order, but because the loading dose itself is going to be a lot bigger than the regular daily schedule. Okay, so that's about the systolic dysfunction. Now we will talk about the systolic, not systolic, but the diastolic dysfunction rather. So what would be the treatment for this patient with a diastolic dysfunction, or known as the ejection heart failure preserved ejection fraction, HFpEF, okay? Heart failure preserved ejection fraction. So the treatment here will involve some general or maybe symptomatic treatment. And so you will see that your patient probably will be getting the diuretics similarly with HFrEF. And so you will be seeing the same kind of diuretics here. There will also be some salt and fluid restriction at this point. There's also going to be daily monitoring of the weight. Okay, make sure that our patient is taught to report any significant weight gain. Okay, that is very important, guys. Now, aside from that, there is also, before we go to that slide, I just want to emphasize here that for the salt and fluid restriction, again, this will be similar to less than 4 grams per day or less than 2 grams per day. And the fluid restriction will be probably around 1.5 liters or 2 liters per day. And we want to make sure that our patient is able to track their weight. Okay. Ejection fraction of pneumothorax? No, ejection fraction of the ventricle. Let me rewrite that. Okay. Rewriting. Pen. Okay. HF. My brains and hands not talking today. Not communicating. Heart failure, preserve ejection fraction. Okay, so we are pertaining to the left ventricle function. Okay. So it simply means that there is preservation of the ejection fraction. Okay, we are talking about the diastolic dysfunction. Remember about the classification that we talked about earlier? There is preservation in the ejection fraction in this classification. And so the problem here is basically inability of the ventricles to relax during the filling phase, or the diastole. So it's despite that there is good amount of blood in the heart or in the circulation, because the ventricles is like in a contracted mode, it's not able to relax. The occurrence here is that the ventricles will not be able to accommodate that desired amount of blood. Okay, so there is less filling. It will still accommodate blood, but it will be a lot lesser. So by the time when it's going to contract, when it pushes the blood out into the circulation or into the lungs, the ventricles will only be delivering lesser amount of the blood. Okay, and the reason for that is because of the resistance in the filling phase. The ventricles are not able to relax properly. Okay, and again, in this type of category or classification, it's not about ejection fraction, it's about the resistance. Okay, now to summarize this, with the diastolic dysfunction, we're going to have to treat that with the diuretics, salt and fluid restriction, and there's also going to be daily weight monitoring. All right, so those are the important concepts that you should retain. Now let's move forward with a question. Now, third question, the nurse is examining a heart failure patient who is being remotely monitored through home healthcare using various electronic tools, including a weigh scale, blood pressure monitor, and daily structured questionnaires answered on a touchscreen device. The nurse is reviewing the information gathered over the previous 3 days. Okay, so the scenario states the nurse is examining a heart failure patient who is being remotely monitored through the home healthcare using various electronic tools, including the weight scale, the blood pressure monitor, daily structured questionnaires answered on a touchscreen device. The nurse is reviewing the information gathered over the previous 3 days. So take a look here into the patient's data for the weight and the blood pressure. So take a look into the trend here. On June 1st, the weight was 65 kilograms. On June 2nd, the weight was 66 kilograms. But on June 3rd, it changed to 68 kilograms. Now looking into the blood pressure reading in the monitor, the blood pressure on June 1st was 119/78. The following day, on June 2nd, it was 129/88. And then the third day, it went up to 140/90. So the scenario is telling us the nurse follows up with a patient. Which question should the nurse ask first? Is it A, how are you feeling today? B, are you experiencing any shortness of breath? C, did you calibrate the scales before using them? D, how much fluid have you consumed in the last 24 hours? Okay, so looking into the trend of our patient's blood pressure and the weight, what do you think would be the first question the nurse should ask the patient? Because this is really significant, guys. And this is now a common trend in our healthcare system in the US. This is what we call as telemedicine. And I once worked in a telemedicine company. It's quite interesting. You're going to be seeing the patient's vital signs real time. Once they have some critical vital signs, let's say hypoxemia or low blood pressure, tachycardia, AFib, you're going to have to call the patient right away once you see those in the system. It's quite interesting. I love it. And so what do you think? I'm seeing answers A, B, 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 A. Okay. So the answer for this test question is actually letter B. Let me mark that one here. Answer is letter B. So without delay, you're going to ask the patient right away, are you experiencing any shortness of breath? Okay. Because while you're referring to the patient's blood pressure and the weight, there is a significant weight gain. How much weight has been gained? That's about 3 kilograms. That is a lot of fluid retained. And take a look into the blood pressure. 140/90 compared to the June 1st or June 2nd. That is a significant increase. There is now hypertension. Okay, so there is consistent increase in the weight and also the blood pressure. So this is going to determine, or this signifies that the patient is having worsening of the congestive heart failure, worsening CHF. And so the patient is going to be asked right away, are you experiencing any shortness of breath? This kind of question is specific, okay? The reason why it's the best answer is because it is specific and it will quickly assess the patient's condition if they are deteriorating, okay? So that is the reason why this is the best question to ask. Why not letter A? How are you feeling today? Well, this is a very general type of question, but does not really directly address the critical symptoms of the heart failure. It may elicit any more subjective findings from the patient, but again, our goal here is to urgently determine the symptom of our patient. We really need to inquire if they are getting so short of breath because of that significant change in their blood pressure and the weight. Yeah, it's very generic. Now, if we had answered letter C, did you calibrate the scales before using them? Well, this is not really going to point out the concern around this time, because the calibration should be done periodically, but it doesn't really address the immediate clinical concern that we are seeing in this patient, okay? So that will happen after we ask them if they're breathing okay or not. Now, if we had answered letter D, how much fluid have you consumed in the last 24 hours? Yeah, maybe you can think that, yeah, this could probably a good question. The fluid intake might factor in, but the significant increase in the weight and also the blood pressure basically indicate that there is rapid fluid retention rather than an excessive fluid intake. Again, the assessment findings that we are seeing, the weight and the blood pressure, they are indicating that there is fluid retention rather than the patient is excessively taking the fluids, okay? So the question itself in letter D, it's not directly assessing the severity of the patient's heart failure, okay? So let me write that down. Does not assess the severity, or let's say does not assess the worsening of the patient's congestive heart failure, okay? So definitely our target here is to ask them, are you breathing okay? Or do you have any shortness of breath right now, okay? If they say yes, well, bingo. They definitely need to get some treatment right away. They are fluid filled. Probably they are in the first stages of the pulmonary edema. Okay, so we got to treat this patient timely. Now we're going to move on to the next test question here. A 62-year-old female patient is admitted to the medical unit, is prescribed lisinopril. Oops. Before I'm going to do that, let me just fix this real quick because I'm seeing an overlap of the test answer or the option and the laboratory data. So this is on page 490. 490, where are you? 490? Okay. Let me just adjust this. All right, very good. All right, let me reread the question. A 62-year-old female patient admitted to the medical unit is prescribed lisinopril, furosemide, and metoprolol for systolic heart failure. Her blood pressure is 134/80 and her heart rate is 68. Before administering medications at 9 a.m., the nurse reviews the patient's lab results. Which action should the nurse prioritize based on the laboratory findings? Okay, so I want you to look into the lab results. Sodium of 142, potassium 6.5, chloride of 102, BUN 19, creatinine 1.0, hemoglobin 30 grams per DL, hematocrit of 38%. So what are you going to do? Are you going to administer the scheduled meds? Are you going to call the medical provider? Are you going to withhold the lisinopril and call the medical provider? And D, are you going to clarify the metoprolol dose with the medical provider? So, calibrating the scales venous redurin is basically making sure that the patient will have to set up the machine first. Make sure that the patient will be following the manufacturer's instruction before they're going to start using the device in order to make sure that it is zeroed down. Okay, so it will be what do you call this? It will be more accurate in measuring the patient's weight. Okay, that's basically what is calibrating. Okay, is it 10 chart? No, this is not INO chart. This is the laboratory data. Okay, or I'm not sure if you're referring to the page. We are on page 490 right now. We are looking into item number 4. Okay, so I am seeing a lot of C's right now. Okay, very good. So what is your answer? Withhold the lisinopril and call the medical provider. So that is the correct answer, guys. Let me explain. Letter C. Withhold the lisinopril and call MD, medical provider, or the medical doctor. All right. The reason that we are withholding the drug, it's because of the hyperkalemia. Good eye, 6.5. The normal value of potassium is supposedly at 3.5 to 5 milliequivalents. Now, you might fight me on here. You probably would say, sir, I've seen books saying 3.5 to 5.3 or 3.5 to 5.5. Let them do that. Let them do that. But I don't care. When I'm taking the NCLEX, make sure that you use this range, 3.5 to 5. Because when you're going to see a 5.1, that is already considered as hyperkalemia in the NCLEX. Okay? But again, in the real life setting, a 5.1, 5.2 could still be acceptable as normal potassium, but when you are taking the NCLEX, use this safe range, 3.5 to 5.0. Okay? Now, the reason that we are going to hold or withhold the medication is because we don't want to cause more elevation of the potassium. Okay? That is the side effect of the lisinopril. So, after you withhold the medication, you're going to call the medical provider. Hey, good morning. I'm calling you about my patient whose potassium level today is 6.5 and he's got lisinopril ordered daily, 20 milligrams. And I just want to make sure that you're aware about the lab result today. Do you want me to officially write this an official order to hold the medication? Okay, so you should communicate to the medical provider about the elevation and that there is that scheduled lisinopril for the day. Okay, so you want to make sure that you obtain a verbal order to withhold the drug. Make sure you write it down as a verbal telephone order, and make sure that by the time the next day comes, of course, the lisinopril will not be active, right? Because it was withheld. So maybe in the next day or the following day, when there is another potassium level, maybe the potassium is going to be 5, or let's say 4.5. Then you need to notify the doctor, hey, our patient this time has kind of like in the safer range of the potassium. Do you want to keep withholding the medication, or do you want us to restart the medication? So this is what you should be doing, especially if you are withholding the drug for this patient, okay? So do not just do it on your own. Make sure that the medical provider is aware that we are withholding this medication. All right, so that is just the process. Charmaine McGill, yeah, correct. We're gonna have to use the SBAR format when we are calling the doctor. Yeah, but I don't have that script today though. I'm sorry. All right, so another reason that we are going to withhold the lisinopril, it's because the patient's potassium can potentially lead to serious cardiac dysrhythmias. Hyperkalemia can lead to dysrhythmias. So we want to make sure that we are not adding to the insult. And we're not going to stop our intervention there. We're not just going to end with obtaining the medication order to be held or to be withheld. We're also going to probably get an order to decrease the elevated potassium. So there's going to be a whole lot of interventions that will follow through. Maybe the doctor will want to order Lasix in order to get rid of excess potassium in the blood. Maybe that's another one. Or maybe the doctor will order Kayexalate to get rid of the excess potassium in the blood by allowing the patient to bind the potassium, or maybe with the administration of Lasix to get rid of the excess potassium. Okay, so those are the possible interventions or pharmacological management to the hyperkalemia. Now, if you had answered letter D, clarify the metoprolol dose with the medical provider. Is there a reason that we need to clarify the dose of the metoprolol? I don't think so. The patient's heart rate is 68, which is basically within the normal range. So there's no concern for clarifying the metoprolol. We're not going to administer the scheduled meds because of the hyperkalemia. And call the medical provider in B option is not specific. That's why it's wrong. And so we are down to letter C, which is the correct answer. Withhold the lisinopril and call the medical provider. All right. So I hope that you're able to capture this rationals. Let's move on to the next. Question number 5. A client diagnosed with chronic heart failure presents with atrial fibrillation and a left ventricular ejection fraction of 18%. The client is prescribed warfarin, Coumadin. What is the intended outcome? What is the intended outcome of administering this medication? Is it A, reduce circulatory overload, B, improve the myocardial workload, C, prevent blood clot, and D, regulate heart rhythm? Thank you. All right, a client diagnosed with chronic heart failure presents with atrial fib and a left ventricular ejection fraction of 18%. That is very low, guys. The client is prescribed warfarin. What is the intended outcome of administering the medication? Is it to reduce the circulatory overload? Is it to improve the myocardial workload? Is it to prevent blood clots? Or is it to cause regulation of the heart rhythm? Thank goodness I'm seeing C's right now, not anything else. That is the correct answer, guys. Prevent blood clot, nothing else. Our patient has atrial fibrillation plus heart failure. and of course, ejection fraction of 18. Let me collect those information real quick. CHF, AFib, ejection fraction of 18%. This is my technique in taking an exam. If I'm allowed to have paper and pen or pencil and pen, I would write down all those very important assessment or lab findings or histories that would help me figure out what really is the cause or the problem. And of course, we're being asked with the medication Coumadin. And our strategy here is to determine the therapeutic effect of the drug. Okay? And again, this is an anticoagulant. Okay? Remember, guys, when we have a patient that has congestive heart failure, so we are back to the avocado heart. So if we are talking about left-sided heart failure, okay, and a pre-existing atrial fibrillation. Remember that atrial fibrillation is just the quivering of the atria. Very irregular atrial contraction. It's not going to effectively cause to transport the blood from the atria, or let's say it will not be able to effectively deliver the impulses, right? And with the dilation, with the cardiomegaly, there will be pooling of blood in the left ventricle. Okay? Or probably it will end up back flowing into the left atrium as well. So the left atrium, let me erase that real quick. Whoops. Go back to the pen. Okay, so the problem here is on the left atrium, the left ventricle. So when there is dilation, cardiomegaly, because of the left-sided heart failure, there will be stasis of blood. I'll just put blood stasis. Okay, why there is stasis? Because of what? The ejection fraction is very low, guys, 18%. When we are talking about the ejection fraction that is 18, it simply means that the ventricle is not going to effectively pump this amount of blood from the left ventricle into the aorta. So there will be a lot of blood that will remain in the left ventricle. Over time, if there is now going to be increasing blood pooling into the left ventricle and into the left atrium, this will cause stasis in the blood. And the more it will cause stasis, remember about the clot formation. Okay? Clumping of those platelets. And it can cause probably the clots to travel from the left ventricle. And then if the patient, unfortunately, if they're going to throw that clot into the brain, what do you think can happen to the patient? They're going to develop embolic stroke. You don't want this, guys. Embolic type of stroke. That clot has migrated from the left ventricle into the cerebral circulation. So the treatment here is to make sure that we are thinning the patient's blood with the use of the Coumadin in order to prevent the clotting, okay? In order to thin the blood, because we want to prevent the clot formation because of the blood stasis. All right, so I hope that you understand the reason why we are giving the Coumadin, okay? And don't forget about the basic concept about the INR, PT-INR. Our goal is to keep the INR level 2 to 3, which is therapeutic for Coumadin. Therapeutic level for the Coumadin. Okay. All right. So that is the reason. It's to thin the blood. Okay. Now let's move forward with the next question. Oh, no. Before we go to do that, let's answer letter A, or let's rationalize letter A. Why not letter A? Reduce circulatory overload. Well, the Coumadin doesn't do that kind of therapeutic effect. This is going to be acted upon by what? The diuretics. Remember? Okay. Now let me erase. There's way too much going on in my slide. So this is going to be acted upon by diuretics. So we are going to eliminate that. What about improve the myocardial workload? What is that? It doesn't do that. The Coumadin doesn't do it doesn't improve the myocardial workload. So what is going to do that? Remember about the inotropes, the cardiac glycosides like the digoxin, okay? Glycoside. And also with the use of some medications such as the ACE inhibitor, it will decrease the systemic vascular resistance, okay? What about letter D? Regulate the heart rhythm. Well, it doesn't do that, okay? So the Coumadin does not regulate the heart rhythm. What can do this are those other medications such as what? The beta blocker, or maybe with the use of the calcium channel blocker. Okay, calcium channel blocker. The Coumadin doesn't have that therapeutic effect in regulating the heart rate. So again, guys, our strategy here is for you to recall the different therapeutic effects of the medications, the drug action, the intent, why we're giving that medication to this patient, okay? And the question was focusing on figuring out why we are giving the anticoagulant, okay? And the reason for that is to prevent the blood clot. No other reason. So the answer is letter C. Now let's move on to the next question here. A client with a history of heart failure is prescribed furosemide, Digoxin, and potassium chloride. The client experiences symptoms of nausea, blurred vision, headache, weakness, and confusion. The telemetry shows first-degree atrioventricular block. Now the nurse should assess the client for signs indicative of which condition? Again, let me reread the question. A client with a history of heart failure is prescribed furosemide, digoxin, and potassium chloride. The client experiences symptoms of nausea, blurred vision, headache, weakness, and confusion. The telemetry shows first-degree AV block. The nurse should assess the client for signs indicative of which condition. Is it A, hyperkalemia, B, digoxin toxicity, C, fluid deficit, D, pulmonary edema? Okay. All right. I'm seeing a lot of B's this time. All righty. So, what I'm going to do if I were you this time, I'm going to have to collect those manifestations rather. There's nausea. There is blurred vision. There is headache. There's also weakness and confusion. And there is also first degree AV block in the cardiac monitor, right? Or telemetry. So these are significant findings in a patient that have digoxin toxicity. That is the correct answer. digoxin. Letter B, digoxin toxicity. All right. So what are those signs of what do you call this? Digitalis toxicity. Yeah, these are the signs. Nausea, blurred vision, headache, weakness, confusion, first degree AV block, and on top of that, I don't like my handwriting, guys. Let me rewrite those to make it easier to read. Yeah, this is my weakness. I tend to write way too fast, and when I come back, I cannot read my handwriting anymore. All right, let's go back to the manifestations of digoxin toxicity. There is nausea, blurred vision. But on top of the blurred vision, guys, there will be halos around light source. I'm adding some more stuff here. Halos around light source. So if when you're going to ask the patient to look out into the fluorescent lamp or any kind of light source, they're going to see that halo around that light. And that is one of the signs of digoxin toxicity. And they're also going to see that green discoloration. Okay, this is probably something that will come out in the exam. Green discoloration in their visual field. Okay, visual field. Eraser. Oh, I'm sorry, guys. I forgot something, but I'll let you know what that is. I got so engrossed with our discussion today. I am. And so the other manifestations here are, yeah, we have the early sign. One of the early sign is the anorexia. One of the early signs, anorexia, nausea, vomiting, anorexia, nausea, vomiting, what else? Confusion, disorientation, okay? Later on, they're going to have those other manifestations. So look for this, ANV, anorexia, nausea, vomiting, confusion, and also the diarrhea. Okay, so those are the most common manifestations of digoxin toxicity. And we still have a lot more here, okay? Now, if you answered hyperkalemia, we don't have that in our data, okay? Our patient has what? Furosemide, digoxin, potassium chloride. These manifestations are not signs of hyperkalemia at all. Letter C, fluid volume deficit. No, the fluid volume deficit option doesn't coincide with the manifestations that we are seeing in the scenario, okay? So same with the pulmonary edema in letter D. The pulmonary edema will typically present pulmonary manifestations such as sudden or let's say progressive shortness of breath. There will be productive coughing with a frothy sputum, which are not described in this scenario. But let me just write them down here. Pulmonary edema is wrong. This one is wrong, and this one is wrong. So the pulmonary is going to be manifested by increasing SOB. There will be productive cough, pink, frothy sputum, and of course, O2 saturation, increased respiratory rate, of course, tachycardia as well. Okay, so those are your typical signs of the pulmonary edema. So it's not coinciding with the manifestations that we have. All right, let's move on to number. Okay, let me just take a look into one of the questions. Srada Karel. If patient have hyponatremia and low BP in congestive heart failure and sodium is restricted, so how should we manage in such condition? Okay, let me reread that. A patient has hyponatremia and low BP in congestive heart failure and sodium is restricted. So how should we manage in such condition? Okay, so the restriction that I was talking about here is intended for those patients that have a significantly, what do you call this? With a the decompensated manifestations of the congestive heart failure, especially if their fluid volume in the body or circulation is way too much. Their lungs is now kind of starting to drown because of the fluid volume overload. Well, of course, if the patient is hyponatremic, we're going to have to treat that. We don't want that hyponatremia to go on without correcting that, because when the patient goes into hyponatremia, this can do a lot of things. So we're talking about sodium level of less than 135 milliequivalents per liter. And the symptoms here will be varied as well. Let's say, for example, if the sodium level is way lesser, maybe 125 milliequivalents, or maybe 115. Yeah, as the sodium level goes down further, there will be newer neurological manifestations, and we don't want those guys. Okay, it doesn't mean that if there is hyponatremia that we're not going to correct that. Yes, we do. We need to make sure that we are safely correcting the patient's hyponatremia in order to not aggravate hypervolemia. We can do that. Okay, you have to be careful when you are replenishing sodium into this patient. And so what we will be doing is probably fluid restriction. Okay, and you said about low blood pressure. Okay, when we are talking about low blood pressure, this is because of the decrease in the cardiac output. So what can we do to increase the cardiac output? Well, we can treat that with the cardiac glycoside, right? Digoxin. Okay, glycoside. So there are things that we can do for that. It doesn't mean that we cannot. And of course, if the care becomes more complex, if the patient will need much more attention, then they're going to need a higher level of care, especially ICU or maybe progressive care unit telemetry, where they're going to be getting maybe inotropes, dopamine, dobutamine, if the case of the patient becomes more severe. And so we're going to treat that problem symptomatically. Okay, so if there is low blood pressure, then we're going to have to end up probably administering vasopressors or inotropes in order to improve the cardiac output. Eventually will improve the blood pressure. If the patient has hyponatremia, we're going to have to add what? Treat that with the hypertonic saline solution, if appropriate, or it could be treated by the use of salt tablets. Have you heard about the sodium chloride tablets, guys? Yes, we can treat the patient with salt tablets as well. And again, this is going to be dependent on the medical provider's decision making, but so far as I have seen in my entire nursing practice, these are the possibilities of nursing interventions, pharmacological interventions that we can do for our patient. Okay, so I hope that answered your question. All right. Now, if we are going to use the diuretic at this point, this will further decrease the blood pressure. So you got to be careful, guys, when you are treating the patient with congestive heart failure. If they have low blood pressure, be careful in giving the diuretic, let's say Lasix. You got to be careful because the duration of action for this medication can last for several hours, let's say 6 hours. So we don't really want to do that. Maybe the patient will benefit the use of other diuretic, which is the spironolactone, which is kind of like slow diuretic. It doesn't really cause a whole lot of excretion in the sodium. It does the diuresis, but not as rapid. So this might be beneficial for the patient as well. Spironolactone. Okay, I think I got so many things said here. I hope that you were not confused. But yeah, I'm just telling you all the pharmacological interventions that we can provide to the patient as ordered. There are so many. You're gonna get busy around this time. Let's move on to the next question. The nurse is assessing a client with left-sided heart failure and should monitor for which of the following signs and symptoms? Select all that apply. Is it dyspnea? Is it B, jugular venous distension? Is it C, crackles? D, right upper quadrant pain? E, oliguria? F, decreased oxygen saturation levels. The question states, the nurse is assessing a client with left-sided heart failure and should monitor for which of the following signs and symptoms. Select all that apply. Is it dyspnea? Is it JVD plus? Is it crackles? Is it right upper quadrant pain? Or is it oliguria? Or F, decreased oxygen saturation levels? ACF. Mary answered ACF. All right, select all that apply. Let me write down the answers here first. Okay, so these are your letters A, C, E, and F. Okay, we are being asked about left-sided heart. No, we are not answering E. Oh yeah, actually, yeah, oliguria. I got so confused for just a second here. All right, why letter A? Let's start with letter A. Dyspnea. Remember that when we are thinking about the left-sided heart failure, pulmonary manifestation. Yeah, it's left-sided heart failure. What about letter B? Jugular venous distension. This is going to be wrong. It's because it is related to the right-sided heart failure. What about the crackles? This is pulmonary, right? A sign that there might be shifting of fluids from the capillary circulation or the pulmonary capillaries into the alveoli, another pulmonary manifestation, though this belongs to the left-sided heart failure. What about the right upper quadrant pain? This is related to portal hypertension, which is basically caused by the congestion of the blood in the venous circulation. So this belongs to right-sided heart failure. Right-sided heart failure. Okay. Right-sided heart failure. And then what about oliguria? Why there is oliguria? I did not include this earlier, guys. This is something that is quite brand new in this slide. Why there is going to be oliguria? Remember that when there is a reduced cardiac output, what's going to happen to the blood pressure? The blood pressure is also going to be decreased. It will decrease perfusion to the kidneys. And what do you think will happen if there is decreased blood flow to the kidneys? Well, yeah, oliguria. The patient's urinary output will be less than 30 mLs per hour. Okay? Oliguria, because of the decreased perfusion to the kidneys. Remember about the 20% of the total cardiac output, must be received by the kidneys every minute. And if there is a reduction in the total cardiac output, well, for sure, the blood supply to the kidneys will be decreased. Okay, so what we will be expecting, oliguria, less than 30 mLs an hour. Actually, let me change that. Not 30, but actually anything within this range. Urine output of about, to be specific, oh boy, to be specific about the oliguria, it will be less than 400 mLs per 24 hours, or could be 20 mLs per hour, up to less than 30 cc's per hour. So that is already considered as the oliguria. Less than 400 mLs in 24-hour period, or within 20 mLs per hour to less than 30 cc's an hour. That is already considered as oliguria. The patient is not getting enough blood flow to the kidneys because of the decreased total cardiac output, decreased blood supply, decreased blood pressure. Okay. Now, if you had answered letter F, decreased oxygen saturation levels, this is going to be closely related to the left-sided heart failure. So this is going to be that. So what are the answers? A, C, E, and F. Erase. A, C, E, and F. All right. Let's move forward. Next question. What signs indicate that a client with a history of left-sided heart failure is developing pulmonary edema? Select all that apply. Is it A, engorged jugular veins? Is it B, dependent edema? C, lack of appetite? D, coarse crackles? E, fast heartbeat? 8. What signs indicate that a patient with a history of left-sided heart failure is developing pulmonary edema? Select all that apply. A, engorged jugular veins. B, dependent edema. C, lack of appetite. D, coarse crackles. E, fast heartbeat. Select all that apply. All right. We are talking about left-sided heart failure. Okay. Okay. So I created a table for you in order to have a reference. If the patient has right-sided heart failure, think about venous congestion, okay? For a left-sided heart failure, most of the manifestations here will be pulmonary and also signs and symptoms of decreased cardiac output, okay? We are talking about left-sided heart failure, so the correct answers are only letter D, and letter E. There's no, well, lack of appetite is not really closely associated with left-sided heart failure. This can be associated with so many others, okay? Non-specific, okay? So let me just put it there. Non-specific manifestation, okay? Let me write down the rationale why we are not selecting letter C. Letter C, the lack of appetite is non-specific symptom of left-sided heart failure. That's why we are going to eliminate that. We're going to eliminate that as well, and we are eliminating that. Okay? So the correct answers that we have are letter D and letter E. Tachycardia and the coarse lung sounds. Okay. Why there is tachycardia? Because of the overwhelming fluid volume in the pulmonary circulation. That is why the heart is struggling. Okay. There is that rapid heart rhythm. Okay. So these are your signs. The ABCs, or just the AB. Engorged veins is going to be right-sided heart failure, while the dependent edema is another sign of right-sided heart failure. Okay? Okay, right-sided heart failure. All righty. Coarse crackles and fast heartbeat, those are the only manifestations that will be closely associated with left-sided heart failure. Let's move on to the next question, number 9. A senior adult with a history of heart failure is brought to the ED with pulmonary edema. Upon admission, which assessment should the nurse prioritize first? Is it blood pressure? Is it skin breakdown? Is it serum K level? Or is it urine output? The question states, a senior adult with a history of heart failure is brought to the ED with pulmonary edema. Upon admission, which assessment should the nurse prioritize first? Is it A, blood pressure? Is it B, skin breakdown? Is it C, serum K level? Or D, urine output? Okay, let me have the answer. The correct answer is letter A. And the reason for that, it's because when the patient has pulmonary edema, the pulmonary edema can actually lead to hypertension. Okay. The increased fluid volume in the circulation and also in the lungs can actually cause that severe hypertension because of that excess fluid volume. And so that is why we are going to check the blood pressure first. That's the simplest reason. Again, when there is pulmonary edema, again, this is caused by what? Fluid volume excess. Okay? Right. When there is fluid volume excess, I'm talking about the bloodstream. This can cause a high blood pressure reading. Okay? Now, if we're going to select letter B, skin breakdown, is this going to be a priority at this point? No. We're going to have to deal with a skin breakdown as soon as we have, we're going to have to assess that further as soon as we have dealt with the most priority assessment, which is the blood pressure. Okay? But again, it's not immediate. Now, we're going to, what about letter C, serum K level? Well, The serum potassium level is also important here, especially in heart failure, but it is not the priority management around this time, okay? As we are talking about edema. When there is pulmonary edema or hypertension, we need to get rid of the excess fluids, okay? We need to address the excess fluid first. Okay, that's why we definitely need to check the blood pressure first. The urine output, yeah, it's also important. Urinary output is one of the nursing interventions that we should keeping an eye on. But again, the priority here that will be more critical for us to assess is the blood pressure. Okay, the urine output is also important, but it's not as high a priority compared to the blood pressure. Now let's move on to question number 10. A client with chronic heart failure who is demonstrating neurohormonal compensatory mechanisms has been assessed by the primary nurse. Which of the following are expected findings on assessment? Select all that apply. Again, a client with chronic heart failure who is demonstrating neurohormonal compensatory mechanisms has been assessed by the primary nurse. Which of the following are expected findings on assessment? Select all that apply. Is it A, decreased cardiac output, B, tachycardia, C, vasoconstriction in the skin, GI tract, kidneys, or D, reduced pulmonary perfusion, and E, fluid volume overload? What do you think? Which of the following are expected findings on assessment? And the scenario is on a patient with CHF demonstrating neurohormonal compensatory mechanisms. All right. So the correct answers for this test question is letters B, A, C, and E. Why? Because in the chronic heart failure, okay, it said here chronic, the body will initiate the compensatory mechanisms in order for it to maintain the cardiac output and also the tissue perfusion. And so when there is a decreased cardiac output, this will now lead to inadequate tissue perfusion, okay? So let's go back to that concept. Decreased CO, there will be decreased tissue perfusion. And with this happens, there will be now an increase in the heart rate, which is a compensatory activation of the sympathetic nervous system, okay? So this is an attempt, again, by the body in order to improve the cardiac output. Now, aside from that, there's also going to be the activation of the sympathetic nervous system stimulation, especially in the GI tract, the kidneys. And so there is that kind of like shunting. There will be shunting of blood. There will be shunting of blood flow to the vital organs. In order to maintain the blood pressure. Now, when this happens, the body will try to activate the renin-angiotensin aldosterone system because of that decreased cardiac output, decreased blood pressure. So this is going to be activated. And once the body is activating that system, it can also lead to so many things. Vasoconstriction because of the angiotensin 2 effect. And there's also going to be retention of the sodium and water in the bloodstream. So there is that corresponding high blood pressure. And also another effect here is the secretion of the antidiuretic hormone, okay, which is going to cause reabsorption of water. Reabsorption of water in the kidney tubules. So the more that the body will be getting excess fluids, okay, that's because of the RAS activation and also the antidiuretic hormone release. So the end result here will be fluid retention. This is the bad end result because of the neurohormonal activation, because of the antidiuretic hormone, and of course with the RAS. And this will now complicate things some more, and that is why it will cause more decrease in cardiac output, because when there is fluid retention, sodium retention, what do you think? The patient's blood pressure will elevate, right? And remember, if there is hypertension, the systemic vascular resistance will also start going up. And when this occurs, there will be increased ventricular workload. The heart will be forced to work harder this time, and it can really cause exhaustion to the ventricles, increase ventricular workload. So all the more, it can lead to a much lesser cardiac output, okay? So we have letter B, tachycardia, which of course, as a result to the increasing fluid in the body, vasoconstriction in the skin, GI tract and kidneys. Yeah, that's because of the shunting. And letter E, fluid volume overload. So it's not really about reduced pulmonary perfusion, okay? It's not about that. All right, let's move forward to what number are we at? 11. The nurse instructs a client with heart failure to take oral furosemide in the morning. The main purpose of this timing is to A, prevent electrolyte imbalances, B, delay rapid drug absorption, B, diuresis excessive fluids accumulated during the night, or D, prevent sleep disturbances during the night. The question states, the nurse instructs a patient with heart failure to take oral furosemide in the morning. The main purpose of this timing is to prevent electrolyte imbalances, B, delay rapid drug absorption, C, diuresis excessive fluids accumulated during the night, prevent sleep disturbances during the night. What is the answer? Well, the correct answer this time is letter D. This is to prevent sleep disturbances, okay? So make sure that the patient is given the medication in the morning to prevent nocturia. Okay, but guys, be careful. Our scenario is stating oral furosemide in the morning. Okay, so this is a diuretic therapy that is not urgent. Okay, so I'll just put here non-urgent diuretic therapy. Okay, so most of the time the schedule will fall in the morning, AM dose. Okay, but guys, if there is an urgency, for example, if the patient has pulmonary edema. So for example, if you're working night shift, right, and your patient develops pulmonary edema on the night shift, it doesn't mean that you're going to have to wait for the morning to treat this patient. No, you're going to have to treat this patient right away because of the possibility that they're having pulmonary edema. You're going to have to administer stat regardless of the time. Okay, so let me just put here in a case of pulmonary edema. This will require urgent diuretic therapy, which is the injection of the furosemide IV. You gotta administer it right away. Do not wait till the morning comes up, okay, or till the morning comes. But in this scenario, this is a non-urgent diuretic therapy. You can give this medication in the daytime schedule, AM dose. All right, that is specific. Now, let's move on to the next item, 12. Which electrolyte imbalances can increase the risk of digoxin toxicity in the client? Select all that apply. Is it A, hyponatremia? All right, before we proceed, guys, I've been so engrossed with our topic today and so many questions as well. We are encouraging you to really enroll in our course online at www.stancoastandclasscoaching.com. You will get the benefit of all the lecture discussions there. We have a huge library of lectures and also the animated videos that can really help you out in understanding those complex concepts. We do have the 200 NGN test questions. Also, mock testings. We have 3,000 NCLEX questions, and you can access this subscription for the entire 6 months, 24/7. All right. Alrighty, we'll get back to the discussion. Where are we at? So let's skip that one. I think we're done with that test question. So number 12, which electrolyte imbalance? Ooh, why are we not in the same page? Okay, let me just wait. Okay, back to here we are. Number 12, which electrolyte imbalances can increase the risk of digoxin toxicity in the client? Select all that apply. Is it A, hyponatremia? Letter B, high glucose level. C, hypercalcemia. D, hypokalemia. E, hypomagnesemia. All right, so these are the electrolyte imbalances in the options. Which electrolyte imbalances can increase the risk of digoxin toxicity in the client? Select all that apply. Is it A, hyponatremia? B, high glucose levels? C, hypercalcemia? D, hypokalemia? And E, hypomagnesemia? I want to see your answers first. Let me just take a look real quick at something. It's been a quite challenging day today. Take your pick, guys. This is a select all that apply. So the course is priced at $130 today. Let me see if it's the same. Okay. Yeah, because days ago, or about like 20 days ago, we had a big discount for that. Let me send you the link. Okay. All right. Let's see. Okay. So I'm seeing the answers here. Melrose answered CDE. Chica answered DE. CD, AD, AB, D, CDE. And we have AJ TV, BDE. High glucose increase the utility of potassium by the cells, which causes the decreased level of potassium. James, Gwen, B, Mary, CDE. Blurred vision. What's the blurred vision? Okay. Marie Fleur answered ABC. All righty. Now let's take a look into the selection right now. We are looking for those electrolyte imbalances that can potentiate the occurrence of dig toxicity. Well, let's take a look on letter A. Hyponatremia. Will it do that? Will it lead to the dig toxicity? No. This is a wrong answer. Let me just mark this right now. That is wrong because sodium does not or is not associated with it's not associated with any of the digoxin medication. It does not affect the action of the digoxin. Let's just put it that way. Now, what about letter B? High glucose level. Do you think that it will directly cause a significant effect on the potassium? Well, no. So this is going to be a wrong answer. High glucose level, which is basically hyperglycemia, do not contribute to the digoxin toxicity. It will not interact with, does not interact with digoxin. I kind of got the explanation from AJI TV that it might cause hypokalemia, but in this situation, we don't know about any history that the patient has diabetes mellitus or anything like that. We are not given that kind of scenario. And so we are just giving a generic information, just imbalances. Or I mean, we're just being asked about imbalances here. And so we're not really going to lean towards thinking about the hyperglycemia that may cause increased insulin release, that might cause a drop in the potassium. Not quite, okay? I see the idea here, but it's not closely related to the digoxin toxicity, okay? Now, what about letter C? Why is letter C going to be one of the correct answers? So the correct answers here are letter C, D, and E. But why hypercalcemia? Anything greater than 10.5 milligrams per DL can predispose the patient to developing the digoxin toxicity. Why? The reason for that, it's because the calcium can actually enhance the cardiac cells. It will enhance entry of the, it will lead into cardiac dysrhythmias. Okay, so let me just make a drawing here. Supposedly this is going to be the cell, okay? Calcium, hypercalcemia, okay? Is it contrast effect? We'll see, okay? The hypercalcemia, okay, so let's just put here the bloodstream. And let's say, for example, elevated calcium level, Ca++, okay? So when there is hypercalcemia, of course, this will eventually be aggravating the automaticity of the heart cells, okay? There will be increasing contractility. Remember about the influx of the calcium? Guys, the effect of the digoxin here, it increases the influx, or let me just simplify, increases entry of calcium ions into the cells. Okay, So this will cause the calcium ions to go inside the cardiac cells. And what do you think can occur if this will happen, especially if there is elevated calcium level? The excitability of the heart cells will be greater. So this will now cause much more of a problem here. There will be cardiac dysrhythmias that can occur, okay? So that is the reason why hypercalcemia is going to lead to more problems. It can enhance the effect of the digoxin, okay? It will. Now, talking about the hypokalemia, let me erase this. When there is hypokalemia, just the answer, when there is low potassium level, what's going to happen? It can also cause excitability. Sorry for my postnasal drip right now. I'm having colds for several days already. Cardiac excitability. And also increasing contractility. Contractility. Oop. Let me see. Contractility. So that is the reason why a hypokalemia with digoxin will not gonna cause a good mix here. It is dangerous. Never gonna be safe whenever there is hypokalemia and digoxin therapy. It will lead to that toxicity. It can cause arrhythmias, okay? The same result, arrhythmias, okay? The same thing with hypomagnesemia, low magnesium level. So this can also allow the calcium ions entering into the cardiac cells. Okay, if there is hypomagnesemia, plus the digoxin, plus elevation of, or let's say decreased magnesium level, decreased magnesium, it can allow the calcium ions to go inside the cardiac cells. The migration of those calcium ions inside the cells, and it will lead into arrhythmias as well. So it's just like you are adding a dynamite into the heart muscle in case if there is hypercalcemia, if there is hypokalemia, or hypomagnesemia, plus digoxin, not a good mix. There's going to be explosion to occur here. Toxicity. Okay, we don't want this in our patient. All right, there's so many explanations about this, but I'm trying to simplify things. Again, any of these conditions, elevated calcium can be life-threatening if we're going to give them digoxin. If there is hypokalemia and if we're not checking the lab value and we are giving the digoxin, yeah, your patient will end up with arrhythmias. Same thing with the magnesium. If it's low, it can also take crushed ginger, hot tea, or hot water. It's a home remedy. Good luck with that. I doubt. And so what you're going to end up having here, if you're not really paying attention to the lab values of the patient, okay, if you're not paying attention to the lab values of the patient, you're going to end up with that problem, digoxin toxicity. But guys, it doesn't end there. If in case the patient will develop the digoxin toxicity, there is that what we call as digibind, which is going to be an antidote for this complication. And this is going to be given IV, but this is that's pretty much it. That's our antidote to digitalis toxicity. Okay, so make sure, guys, your role here or responsibilities, it should be to what? Check K, check magnesium, check calcium levels. Also, check digoxin level in the blood, and also make sure that you are replenishing needed electrolytes as ordered. Okay, so what are these electrolytes that we need to replace? Could be the potassium, could be the magnesium. Okay, because these two electrolyte imbalances, like low magnesium and low potassium, these are known to cause digitalis toxicity with the digoxin therapy. Okay, so we need to administer those medications as needed, as ordered. Okay, now let's take a look into the next test question here, number 13. For a client taking a loop diuretic, which foods should the nurse encourage them to eat? Is it select all that apply? Where did that come from? Again, the test question: for a client taking a loop diuretic, which foods should the nurse encourage them to eat? Select all that apply. Is it sponge cake, B, banana, C, dried fruit, D, orange juice, E, bell peppers? Okay, the correct answers here are letters B, C, and D. These are high in potassium. Okay, sponge cake, low in K, bell peppers, low in K. So we have these three food items: banana, dried fruit, orange juice. Okay, we really want to make sure that we are maintaining safe K level. Okay, do not forget the 3.5 to 5.0 milliequivalent value. Okay, make sure that you're able to maintain that. Okay, so the reason that we are going to do that teaching to the patient, because they're going to be using the loop diuretic daily. Okay, they will be taking this for quite some time, and the bad thing about taking the loop diuretic is that it can cause hypokalemia, also hypomagnesemia. And so we want to make sure that our patient has that safe potassium level in their bloodstream, and so they're not going to be able to experience any more of that complications. All right, moving on to the next. During the assessment of an older adult, the nurse discovers the apical impulse below the fifth intercostal space. The nurse should further assess the client for A, left atrial enlargement, B, left ventricular enlargement, C, left atrial enlargement, or D, right ventricular enlargement. Again, the question states, during assessment of an older adult, the nurse discovers the apical impulse below the fifth intercostal space. The nurse should further assess the client for A, left atrial enlargement, B, left ventricular enlargement, C, right atrial enlargement, D, right ventricular enlargement. Okay, so what is the answer? The answer for this item number 14 is letter B. Remember about that apical impulse that kind of migrated below the fifth intercostal space. Remember about that point of maximum impulse that is no longer in the original location between the fourth and the fifth. So this is going to be associated with the left ventricular enlargement. Okay, remember about the left-sided congestive heart failure that I mentioned earlier? Yeah, that is the correct answer. Left ventricular enlargement. And this is caused by the chronic hypertension. It's caused by the aortic stenosis, the myocardial infarction. Okay? Now the rest are all erroneous. This is an easy question. Moving on to the next. Okay, here we go. Supposedly, our point of maximum impulse is right here. 1, 2, 3, 4, 5, right here. But when we have that PMI going lower than the fifth ICS, maybe it's going down here, that is a sign that there is LV enlargement. There is already cardiomegaly. Okay, so the PMI is going to be spotted below or in this location. Okay, now let's move forward to the next question, number 15. When educating a client with heart failure on preventing complications and hospitalizations, which issues mentioned by the client as reasons to contact the physician would indicate to the nurse that the client has grasped the teaching? Select all that apply. Let me reread. When educating a client with heart failure on preventing complications and hospitalizations, which issues mentioned by the client as reasons to contact the physician would indicate to the nurse that the client has grasped the teaching? Is it A, experiencing more difficulty breathing at rest, B, gaining 2 pounds or 0.9 kilos or more within a single day, C, consuming a large amount of sodium during breakfast, D, needing to sleep in an upright position in a recliner, and E, losing 2 pounds, 0.9 kilos in a single day. Okay? So our task here is to educate the patient on preventing the complications of and hospitalization. So we are going to select all of those items. It said here, preventing complications, hospitalization. Which issues mentioned by the client as reasons to contact the physician would indicate to the nurse rather that the client has grasped the teaching. So basically we're going to select those patient reports or complaints that simply means that they need to early notification to the medical provider. Simply means that they know what possible complications that should be reported. Okay, so what about letter A? Experiencing more difficulty breathing while at rest. Yeah, that is one. So that's the one answer right there. This is going to be a SATA. So one of the answers is letter A, one is letter B, and another is letter D. Okay. Why letter B? Gaining 2 pounds or more within a day. This is significant. This is a significant weight gain. Within a day, that is a lot. Okay, so that is another correct answer. What about consuming a large amount of sodium during breakfast? Consuming a large amount of sodium at breakfast, it's not going to really crucial. The restriction is the restriction of the sodium during exacerbation of heart failure is crucial, right? But a single high sodium meal will not typically warrant immediate notification to the physician, okay? Unless the patient will have some accompanying manifestations of fluid overload. Okay, so a single ingestion of sodium will not really warrant notification. Okay, it doesn't, unless if there is now an associated difficulty of breathing, hypoxemia, or other signs of CHF exacerbations. So we are not selecting letter C. What is the last answer then? Needing to sleep in an upright position and a recliner. This is a sign that the patient has what? Orthopnea. Elevation. Okay? This is worsening CHF. It simply means that they understood the teaching that they should be informing the medical provider right away once they experience this manifestation. Now, letter E. Why letter E is wrong? Well, it says about losing. Losing 2 pounds of weight is good. It's not a bad thing. We don't want excess. Losing 2 pounds of weight in a single day. This could be possibly excretion of excess fluids, right? And so that's not going to be a reportable manifestation. We're going to eliminate that as well. Okay, so we are left with letter A, letter B, and letter D. All right, and I believe we still have one more test question. Let's move forward. Number 16, a 78-year-old client with a history of heart failure is admitted with the symptoms of nausea and vomiting. The client is receiving Digoxin and has been nauseated for a week with vomiting starting 2 days ago. Lab results show hypokalemia. Based on these findings, the nurse should carefully assess the client for signs of A, chronic kidney disease, B, heart failure exacerbation, C, digoxin toxicity, D, metabolic acidosis. Okay, our patient, 78-year-old, diagnosed or history of heart failure rather, symptoms of nausea, vomiting, receiving Linoxin, nauseated for times 1 week. Nauseated for a week with vomiting starting 2 weeks ago or 2 days ago. And lab results show hypokalemia. Based on these findings, the nurse should carefully assess the client for signs of dig toxicity. Very good. Very good. Letter C. Nothing else. The chronic kidney disease is not associated with this scenario. The chronic kidney disease will typically have hyperkalemia. That is why we are eliminating that. No hypokalemia in chronic kidney disease. They will tend to have conservation of the potassium. That's why they're going to end up with this electrolyte imbalance. What about heart failure exacerbation? Why letter B is wrong? Well, we know that with congestive heart failure exacerbation, this can lead to fluid retention and may also lead to nausea and vomiting. But the presence of the hypokalemia specifically, it will specifically point out to digoxin toxicity rather than the heart failure exacerbation. That's why this is also incorrect. Now, letter D, metabolic acidosis. This is also wrong for the reason that the patient will not be developing metabolic acidosis. Remember that when the patient vomits, in how many days? 2 days. They're prone to develop what? Metabolic alkalosis, not acidosis. Okay, so this is wrong. Supposedly, it will be metabolic acidosis, not no, it's supposed to be metabolic alkalosis, not metabolic acidosis. All right. So don't forget about the association with the acid-base imbalance with the manifestation. So make sure you reread that situation carefully. Okay. All right. Metabolic alkalosis. Yeah. And lastly, we have the question number 17. An elderly client admitted with heart failure is receiving IV Lanoxin and furosemide and reports continuous ringing in the ears, tinnitus. What should the nurse do next? An elderly client admitted with heart failure is receiving intravenous digoxin, furosemide, and reports continuous ringing in the ears, which is tinnitus. What should the nurse do next? Is it A, assess digoxin levels to determine if toxicity is present? B, record observations and schedule a follow-up assessment in 2 hours? C, ask about the client's usage of aspirin in combination with other medications? Or D, discontinue furosemide and notify the physician? Okay. All righty. Our correct answer this time is letter D. We are talking about the Lasix, okay? The side effects of Lasix, it can cause ototoxicity. Excuse me. And it can also lead to the tinnitus, ringing of the ears. And ototoxicity will call for a discontinuation of the medication. All right. You have to withhold the medication or discontinue, probably initiate, but it doesn't stop there. You need to make sure that you notify the physician that the patient now is developing the tinnitus. So in order that they can officially order the discontinuation with the use of the Lasix. All right. So you should let them know right away to make sure that they can provide alternative treatment. Notify the medical provider or the doctor for alternative diuretic therapy. Okay. Yeah. So we want to make sure that we're going to have to continue with the treatment with an alternative pharmacological agents as ordered. All right. If we answered letter A, assess digoxin levels to determine if toxicity is present. Digoxin toxicity is not associated with tinnitus. No, never been. So we are going to eliminate that one right away. That's an easy one. Record observations and schedule a follow-up assessment in 2 hours. No, you don't need to have a reevaluation here. Once the patient develops tinnitus, if they have been taking the Lasix, discontinue that, report it to the medical provider. Ask about the client's usage of aspirin. Will it help? Yeah? Well, to tell you guys, aspirin also can lead to tinnitus, but it's not included in the therapy. Okay. Ask about the client's usage. Yeah, I think it's important, right? But the recent onset of the symptoms is more likely that this is due to the furosemide. So take a look into the situation here. An elderly client admitted with heart failure is receiving IV digoxin and furosemide Lasix and reports continuous ringing in the ears. So this is going to be associated with that medication that has been recently been given. Okay, because if we are going to entertain this idea about the aspirin, this tinnitus could have probably been going on. I mean, if there is that prescription previously that the patient has been taking the aspirin, then they could have experienced the tinnitus way before the patient received the IV Lasix. So that is why letter C is going to be eliminated. Okay, so our correct answer is letter D. That is the safest option. Alrighty. So again, I am encouraging you to enroll into our course, the NCLEX course, at our website at www.stancoast-coaching.com. Please check out our website so you will be able to see the pricing there. And also we have the different videos that you can use offline for your own study. We have a wide range of video lectures, and so also the 3,000 NCLEX questions plus the NGN test questions there, and some more of the study guides that we have offered. And so for today, I really thank you for your participation. It's quite a long session already. I hope that you have learned something from this lecture. And if you do have any more questions, if you need clarification regarding any of the content, please comment in the section and make sure that we will be able to follow through. Okay, so I'll see you again tomorrow at 9 p.m. Eastern time. We'll be talking about the valvular heart disease. All right, so thank you so much. I appreciate your participation, and you all take care. All right, bye-bye.